fourth meeting of the House of Commons Standing Committee on Justice and Human Rights. Today's meeting, as you all know, will be in hybrid format. The proceedings will be made available via the House of Commons website. Just so all of you are aware, the webcast will show the person speaking rather than the whole committee. In order to ensure an orderly meeting, I'd like to outline a few rules to follow. Members and witnesses may speak in your official language. Just make sure that you're picking the correct interpretation at the bottom of your Zoom call, whether it's in Floor, English, or French. For members participating in person, please ensure that you're following health protocols regarding masking for the safety and security of yourself and staff. Before speaking, please allow me to recognize you by name. For those that are participating virtually, please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled by the Proceedings and Verification Officer. Use the blue hand raise function if you would like to speak. That is the best way for us to know that you're wanting to speak. A reminder that all comments by members and witnesses should be addressed through the chair. When speaking, please speak slowly and clearly. And when you're not speaking, please be on mute. With regard to the speaking list, the clerk and I will do the best that we can to maintain a list of speaking order. And I will say that those that are speaking with respect to timing, I have two cards. I have a 1-minute card that I will show and a 30-second card that I will show to ensure that we're keeping on track so that the whole meeting can stay on track. Now, before we proceed with the hearing today with our phenomenal ministers, I will allow for the legislative clerks to give a short presentation. The Legislative Counsel for Bill C7, that's Alexandra Scora, and the Legislative Clerk, Philippe Mela, and they'll be, for 5 minutes, they'll tell you on how things will operate with respect to any amendments throughout the bill. So at this time, please go ahead, Alexandra and Philippe, you have 5 minutes, and any questions that members may have will be referred to you via email instead of in this forum. Thank you. Please go ahead.
Point of order, Madam Chair.
Yep, go ahead, Mr. Moore.
Yeah, we have the ministers with us for 1 hour. I'm very eager to hear from them and ask questions of them. Perhaps we can have the presentation from the legislative clerks at some other time, because we're not right now. We're talking about the bill. Amendments are going to come later, so I think we can have that type of discussion once the ministers have left in 59 minutes.
Thank you for raising that. Monsieur Thibault, is that on the same question? You had your hand raised? You're on mute, sir.
J'avais levé la main.
Yes, I had raised my hand much earlier, but you hadn't seen that. I strictly wanted to note that when the witnesses, whether they're ministers or other witnesses, are reading, and when they're quoting, that they must speak slowly so that the interpreters will be able to properly interpret. And also for the speed of which you're speaking, I'd like people to remember that people are working to simultaneously translate. And I think that you need to have a particular sensitivity to that, because we are moving into a work that is very sensitive and every word counts. Thank you.
Merci.
Thank you very much for your intervention, Mr. Terreau.
To speak as slowly as possible and to make sure that everybody in our committee does the same. Merci pour vos.
Thank you for those words.
Going back to Mr. Moore's question, Mr. Moore, it's going to take 5 minutes. I'll ensure that it's equitable. I do feel that it's necessary for everybody to hear from the legislative clerks. I'll do a quick thumbs up, thumbs down from the committee if that's okay that we hear from the legislative clerks at this time, or we can schedule them at a later time. Okay. Okay. All right. Well, I see that we don't have consensus. So at that time, then, Philip and Alexandra will invite you in at a later time. So it gives me great pleasure to introduce and to welcome Ministers David Lametti, the Minister of Justice and the Attorney General of Canada, Honorable Patty Hajdu, who is the Minister of Health, and the Honorable Carla Qualtrough, the Minister of Employment, Workforce Development and Disability Inclusion, as witnesses before this panel. So you will have 4 minutes each for your opening remarks. Minister Lametti, we'll start with you. The floor is yours. Please go ahead.
Merci.
Thank you, Madam Chair, for the invitation to appear before this committee to discuss Bill C-7, an act to amend the Criminal Code, Medical Assistance in Dying. I would like to say hello to my colleagues, Madame Hajdu and Madame Qualtrough, and I would like to say that François Daigle is also the Associate Deputy Minister who is with me here and who is on hand to be able to help me if need be.
Bill C-7 proposes an important change to our medical assistance in dying or MAID regime. It would repeal the eligibility criterion requiring that natural death be reasonably foreseeable, and this is in direct response to the decision in Truchon. This legislation will prioritize the individual autonomy of Canadians who are suffering to choose a peaceful death if they determine that their situation is no longer tolerable to them, regardless of proximity to death.
Other aspects of Bill C-7 are associated with this important change. First, Bill C-7 proposes to exclude persons whose sole medical condition is a mental illness, who would otherwise become eligible through the removal of foreseeable death as a condition of eligibility. Experts disagree on whether medical assistance in dying can ever be safely made available in such cases. While those with mental illness can suffer unbearably, unpredictable illness trajectories mean that there is always the possibility of improvement and recovery. And it can be especially difficult to tell whether a desire to die is a symptom of the illness or a rational response to it. The exclusion gives Parliament more time to reflect on this complex question, which is fraught with serious risks, to determine whether it is possible to craft a safe MAID regime for this category of persons. I fully expect this issue will be examined in the course of the parliamentary review of the MAID legislation.
The bill proposes to tailor procedural safeguards to the risks associated with assistance in dying for persons who are not nearing death. Ending the life of a person whose suffering is based in the lived experience of their medical condition is different than alleviating the suffering associated with the dying process that is already underway. Bill C-7 therefore proposes different safeguards based on whether natural death is reasonably foreseeable. Reasonable foreseeability of natural death refers to a temporal but flexible connection to death. It does not require imminent death or a specific prognosis, but a practitioner must be able to anticipate the person's death based on their individual medical circumstances in the near term.
Safeguards for those whose deaths are not reasonably foreseeable are built around the existing safeguards with some important enhancements that seek to ensure that adequate time, expertise, and exploration of alternatives are devoted to assessing MAID requests from this group. The existing set of safeguards for those whose death is reasonably foreseeable would be maintained, with two modifications that my colleague will discuss because they are tailored to this context. We believe these changes to the safeguards strike the right balance between individual liberty and public safety for both groups of eligible persons.
Allow for the waiver of final consent in specific circumstances, so that people whose death is foreseeable don't choose to die earlier than they want or refuse pain medication because they fear not being able to consent on the day of the procedure. This targeted and prudent change would address unfairness in these situations. I will turn it over, Madam Chair, to my colleagues for their remarks. Thank you.
Thank you very much, Minister Lametti. We'll now go to Minister Hajdu for her remarks. Please, for 4 minutes.
Thank you very much, Madam Chair, for inviting us today to speak about proposed amendments in Bill C7. Je crois que le
I believe the proposed changes to Bill C7 will expand freedom of choice for people who are suffering intolerably. It will strengthen safeguards to protect vulnerable individuals and respect individual autonomy.
4 years, we've heard from Canadians, from families and healthcare professionals who have told us that there are critical issues with medical assistance in dying that need to be addressed. And with C7, we are doing that work. Among the feedback that Canadians raised is the mandatory 10-day reflection period. I must note that a dying person's decision to pursue medical assistance in dying is a carefully considered one. We heard that story over and over. We heard that the 10-day reflection period prolongs suffering. So we removed this requirement for people whose natural death is reasonably foreseeable. On nous a également affirmé.
We also heard that the requirement for 2 witnesses creates a barrier to access. After careful consideration, we reduced this requirement to 1 witness and are confident this change doesn't pose any risk.
For consideration of advanced requests. But this is a complex issue, and we believe it ought to be pursued in the context of the parliamentary review. But we also believe that we should address those situations where an individual nearing the end of life has requested and been declared eligible for MAID, but finds themselves worrying about the time of their medical assistance in dying procedure. They could be worried because they don't know if they'll lose capacity before their procedure if they choose a date that would extend their life. The majority of practitioners consulted on this issue are in favor of permitting a waiver of final consent in these limited situations. Je sais que
I know that there is concern that these changes go beyond what is required to respond to the Truchon decision.
Let's remember that Truchon, in effect, created the need for a 2-stream system of access to MAID, one for individuals who are suffering grievously, but whose death is not imminent, and the other for those whose death is reasonably foreseeable and have been eligible since 2016. It is essential that we set a higher bar in terms of safeguards for the first group, while providing relief from barriers to access for the second. And that is what we are doing in Bill C7.
Madam Chair, the proposed amendments for our health system in delivering MAID and reflecting the opinions and perspectives shared by Canadians and a wide range of stakeholders.
They represent a balanced and compassionate approach with respect for personal autonomy while ensuring adequate safeguards are in place to protect vulnerable individuals. They also reflect the many hundreds of thousands of voices that took the time to consult with to consult with the government. Thank you very much, Madam Chair.
Thank you very much, Minister Hajdu, for your remarks. We'll go to Minister Qualtrough now for 4 minutes. Please go ahead, Minister.
Thank you, and good morning, everyone. I'm here today with my cabinet colleagues to share the perspectives of persons with disabilities on this important and personal issue. Medical assistance in dying is a human rights issue. The proposed legislation recognizes the equality rights of personal autonomy, as well as the inherent and equal value of every life. This is what disability advocates have fought tirelessly for decades. In doing so, it remains true to the Charter of Rights and Freedoms, the United Nations Convention on the Rights of Persons with Disabilities, and the principles of the Accessible Canada Act that everyone must be treated with dignity, everyone must have meaningful options and be free to make their own choices, and everyone must have the same opportunity to make for themselves a life that they are able and wish to have, regardless of their disabilities. As we looked to broaden access to MAID as directed by the court, we were very aware of the need for Canadians to know their options, to ensure that their consent was informed, to have a real choice. Equality rights, personal autonomy, human rights, meaningful options, and the opportunity to make a good life for oneself are top of mind. If our systems, processes, programs, and services don't offer these options, and if our citizens don't see that these options are available to them, then their equality rights are not being fully realized. This proposed legislation recognizes a significant role that social, mental health, disability, and community support services play in the full realization of equality rights. Accessing MAID should not be easier than accessing disability supports. The new legislation makes it the responsibility of the medical practitioner to ensure that the individual is made aware of the supports that are available to them and that they have been seriously considered. The harsh reality is that many Canadians with disabilities are not living with dignity in the sense that they're not properly supported, face barriers to inclusion, and regularly experience discrimination. The pandemic has shown us that many of our systems are not able to truly support and include all Canadians. Canadians with disabilities, as well as many other marginalized communities, rightly demand that governments address these inequities. Moving forward, we'll continue to work with the disability community. Will not shy away from the long overdue conversations that we need to have in our country with respect to disability inclusion and the systemic barriers to inclusion that continue to persist. We'll also take action, as laid out in the throne speech, by bringing forward the first ever National Disability Inclusion Plan, one that provides systemic changes to how the federal government interacts with and supports its citizens with disabilities. We have before us legislation that seeks to balance making medical assistance in dying available without undue obstacles to those who choose it, with safeguards to ensure that this decision is truly informed and voluntary. For a truly progressive medical assistance in dying law is one that recognizes without compromise the equality rights of everyone. Thank you.
Thank you very much for that, Minister Qualtrough. I really appreciate the succinct and quite informative remarks by all three ministers. Really appreciate it. We'll go right into our rounds of questioning, starting with the Honourable Rob Moore for 6 minutes, please, sir. Your time starts now.
Well, thank you, Madam Chair, and thank you to our three ministers for being here today on this important piece of legislation. Minister Hajdu mentioned something, that the Turchon decision created the need for a two-track system with regard to assisted dying. And in fact, nothing could be further from the truth. And it leads me to my question. It was the failure of this government to defend its own legislation that had passed in a majority Liberal Parliament on June of 2016. So just 3 short years later, when this legislation is challenged at a lower court, instead of appealing, as we called on them to do, instead of appealing as the disability community called on them to do, this government chose at the first possible opportunity to, in fact, not defend their own legislation. There were numerous organizations that raised alarm bells over the expansion of MAID last year in response to this Quebec Superior Court decision. And we've all had the opportunity to hear from many in the disability community, those that are most vulnerable in our society. And the message that this legislation sends, that no longer do you need to be dying to access assisted dying, is a fundamental change in our country. A letter was sent to Minister Lametti and Minister Qualtrough's office, signed by 72 organizations across our country that assist Canadians with disability. They do honorable work helping those that are most vulnerable. They wrote that a failure to appeal the decision would be be a failure, quote, on the part of your government to defend persons with disabilities from significant tangible harm. And we know that the bill before us strips away many safeguards that it's not required to do, even under the Turchon decision. So my first question to Minister Lametti is, why, through you, Chair, why didn't your government take the concerns raised by these organizations who help Canadians with disabilities when deciding not to appeal this lower court decision? It is the job of the Attorney General, and it's a job of a government to defend its own legislation. Thank you.
Thanks very much, Mr. Moore, for that question. It's an important one. It was a difficult decision, and we did hear various voices, including voices from the disability community. We took the decision, put quite simply, to reduce suffering. It was hard to see cases like Nicole Gladu and Jean Turchon and Julia Lam out west and not see the suffering that they were going through with no recourse to medical assistance in dying that other Canadians had. When the legislation was passed, there were concerns raised at the time about whether or not the proposed regime was in conformity with the Charter, and in particular the Carter decision. And given the experience, the very positive experience with MAID that Canadians had since 2016, and the real moving of the goalposts that had occurred from 2016 to 2019, we felt we could reduce the suffering of Canadians by moving simply to implement the Superior Court decision without waiting for further suffering and appeals and that sort of thing. And we could also meet the concerns, very legitimate concerns, raised by the disability community about valuing the dignity of life. And we think we've done that in this bill.
Thanks, Minister. Madam Chair, this government decided not to defend their own legislation at the first instance, and which is incredibly unusual and, in fact, offensive to Parliament who passed the legislation. And Minister, we know that rather than appealing the Superior Court decision, you chose instead to introduce this bill, which in fact goes far beyond simply responding to the decision. This was all done before a parliamentary review that was supposed to take place under your government's own legislation. So why did your government choose to skip an important parliamentary review that was supposed to look at MAID in the Canadian context after C-14 was passed? Why did you skip that review and instead go beyond what was required in the Turchon decision?
Again, thanks to Mr. Moore for the question. We're not skipping anything. We're still going to go ahead with the parliamentary review. That's going to look at very important issues that were identified and further studied by the Council of the Canadian Academies, amongst others. So the question of advanced requests, the question of mental illness as the sole criterion for MAID, and the question of mature minors, as well as any other things that came up. We saw, again, from 2016, we were going to reduce the suffering and respond to the Turchon decision. But we saw that there were other cases, such as Audrey Parker's case, where Canadian society had moved. And we had the lived experience from the medical profession and from families to say, here are some changes that can be made right now to reduce people's suffering. And so we've chosen to do that. This is a very responsible thing to do, but by no means are we skipping the larger parliamentary review. That's critically important to moving forward as Canadian society moves forward.
Thank you very much for that, Minister Lametti and Mr. Moore. We have Mr. Kellaway next for 6 minutes. Mr. Kellaway, the floor is yours.
Thank you, Madam Chair, and hello, colleagues and staff, and hello to the ministers, and thank you for coming today. This question is through you, Madam Chair, to Minister Lametti. Audrey Parker was a strong woman who lived in my province my home province of Nova Scotia. In Audrey's case, the issue around advanced consent or waiving the final consent was very, very heart-wrenching. Can the minister please explain how that case informed his decision to propose the final consent waiver outlined in BC 7?
Thanks very much, Mr. Callaway, for that question and reminding us of Audrey Parker's courage. As you know, she had terminal cancer, was in her final stages. She wanted to spend one last Christmas with her family, but because of the regime that is currently in place, she was very fearful that she would lose the ability to consent finally to the procedure. And didn't want to continue to live in the situation after that. So she took MAID before being able to spend that final time with her family. It was a gut-wrenching set of facts, and it resonated across the country, in English and in French. There was an outpouring of support for Audrey Parker and for the ability to give an advanced consent or waiving final consent, as we have framed it in this legislation. So what we've done in this particular case to meet the Audrey Parker example is where a death is reasonably foreseeable. So we're in the foreseeability stream. When someone has been assessed and approved, and they've made an arrangement with their MAID practitioner to waive final consent, then if they do lose capacity at the end, then they can the MAID practitioner can go through with it. The other thing that was happening is people weren't taking their pain medication at the end for fear of losing that final capacity. And so again, all we're doing here is we're alleviating suffering. The wide consensus across Canada for this particular amendment to be added now, and widespread support.
Thank you, Minister, and I really want to thank you for that very thoughtful answer. I'm going to stay with Minister Lametti. Through you, Chair, to the Minister. Minister Lametti, you stated that during consultations that you heard that the 10-day waiting period between signing a request for MAID and receiving MAID is an unnecessary prolonging of suffering. And I can only imagine how trying these 10 days must be. Can the Minister please elaborate on these findings in the consultation process?
Thanks very much for the question, Mr. Callaway. And again, as Minister Hajdu pointed out in her remarks, what we heard almost universally from coast to coast in Canada, from people who were helping to provide MAID as a service, so doctors and nurses and other people in the health profession. Hi, Ramesh. As well as families who had gone through MAID, they were telling us the decision was already made. They'd gone through the evaluation, they'd taken it seriously. They had to wait another 10 days, suffer another 10 days, in order to get to that at the end of that 10-day period. Often they weren't taking their medication, their pain medication, because as I'd mentioned in my previous answer, people were worried that they would lose that capacity to finally consent. And again, even after we proposed this bill, I've had friends who've lost family and had access to MAID said, look, you've got to get rid of the 10 days. All it does is it increases people's suffering. The decision was made. It was serious. Let people get on with it and let their families get on with it.
Madam Chair, can I add to that response? Sorry to jump in, but
Please, go ahead.
Thank you so much. I just wanted to point out that this reflection was also on behalf of the practitioners who were providing medical assistance in dying. They noted, and I have to say, I've never met a more thoughtful group of people. You know, they're helping people make decisions that are very profound, and many of actually all of the practitioners noted to us that they felt that the additional 10-day waiting period was in many cases undue cruelty, and they felt that by the time that a person got to the place where they had thoroughly searched their souls, thoroughly explored their options with their family members, etc., knew that there was a finality to their days, that this reflection was deep, it was considered, And it was profound, and that the additional 10 days did nothing to help that person reflect. In fact, all of that reflection had happened prior to even asking for MAID, and the assessment period and the offering of additional services had already happened. And so, I just want to reiterate that this was not just from the perspective of the families and obviously the patients that we've got some very famous examples of, but it was also from the perspective of the practitioners, of which we owe a debt of gratitude to, because they are truly some of the most thoughtful practitioners that we have, doing immensely, I think, deeply important work in our societies.
They are incredible people. Thank you, ministers.
Mr. Kellaway, you have 5 seconds, so I'm just going to skip your 5 seconds if that's okay.
That's okay with me.
Thank you. Moving on, Monsieur Thérault, voulez-vous commencer pour 6 minutes?
Merci.
Thank you. Thank you, Madam Chair. Ministers, colleagues, welcome. First, I would like to say that while we are asking questions as to clarifications with respect to this bill, there are people who are suffering. And since the adoption of Bill C-14, people are suffering, and we can't ignore this, because the Baudouin decision has told us that this was unreasonable suffering based on Article 1 of the Charter. And we've been told that C-14 was taking away a fundamental right in Section 7, that is the right to life, not simply to right to security of the person, the patient, but the right to life of the patient, because it was meaning that they had to shorten their life, being afraid that they would not be able to give their consent once they had lost capacity to do so. And the minister has just spoken about the Parker situation. And that is where we need to be aware, and we need to work on that today. There are two elements, two visions, two philosophies, if you will, that are going to be in opposition here. There is a state paternalism, and it has repercussions in medical paternalism, and there is a vision that is based on the principle of the right to autonomy of a given person. So those are two visions that will be in opposition. And the question we need to ask ourselves is, why at the most intimate moment of a patient's life, why is the state coming in, getting involved in a decision, in the autonomous decision of a patient to decide on their own death? Contrary to my conservative colleague, I would like to congratulate the Minister Lametti for this proposal he's making today. I think that he is looking at a large consensus. So do you have any numbers with respect to the acceptability of C7, Bill C7? Across Canada and across Quebec, I think, at least for Quebec, I think we do have a broad consensus. Elsewhere, what is the situation? Minister Lametti. Thank you, Mr. Thériault, for your question and your observations. I think the consensus is roughly the same across Canada. So the numbers that we see in Quebec, and I have seen the Quebec numbers, and it's over 70% that are in favor. This is true across Canada. And therefore, the support is there. And I would like to note, following what you've said, one of the greatest changes since 2016, it's the change in the medical community. In 2016, there were great concerns. And as the minister noted in her answers, across Canada, we have consulted and online, and it was the medical community, doctors and nurses, who came forward with positive suggestions and who accepted the fact that this is a positive step forward in a family's life and in an individual's life. And it is a right to die in dignity. And I think this is a change that I was really strongly affected by. What practitioners need is a clear legislation. However, the criteria of natural death that would be reasonably foreseeable was not a clear criterion, and it would allow for a multitude of interpretations, and it would exclude people, as Madame Gladu and Mr. Truchon, who did proceed, and it probably wouldn't have been an adequate test with respect to Audrey Parker, because we would have had to ask the Supreme Court. So now let's move forward. The patient has to be heard. Right now, it will occur that because we're opposing palliative care to MAID, and because there are not enough resources for palliative care, people who need palliative care are against MAID because they say it's an emergency exit, if you will. But that's because there's not enough care in a hospice situation. So have you noted that there was this polarity between MAID and between hospice care, and that people in palliative care think that we're not doing enough and this is a solution when it comes to dying with dignity? I will start, but I think that I will let the Minister Hajdu continue. What I've seen over the consultations is that there's some doctors who could see both sides of the story. They saw MAID would be an option with palliative care, and so it is part of a whole spectrum of response to obviously tragic circumstances, but it is not necessarily something that is in opposition or negative. So yes, of course, we need to work with the provinces to be able to ensure that palliative care is available. And also, just as Minister Qualtrough has said, there is also the possibility to live with dignity, with the support that would be available. And so that needs to be clarified.
We are out of time at this time. I will go to Mr. Garrison, please, for 6 minutes. Your time starts now. Go ahead, Mr. Garrison.
Thank you very much, Madam Chair. And I'd like to give the Minister of Health an opportunity, since I know she was wanting to answer that question.
Thank you very much, through the chair, to MP Garrison. I am excited to talk about palliative care because I think things are improving in that area, and certainly Budget 2017 committed $6 billion to provinces and territories to ensure that they could increase access to palliative care, something that I think is intertwined with this issue, as so many MPs have noted, as the minister himself has noted, that MAID is not, it does not exist in isolation outside of a palliative care framework. In fact, the majority of Canadians that have accessed MAID have utilized palliative care. In fact, 82%. And even those that didn't access palliative care, the majority of those, the remaining, 13% or so, had access to palliative care in most cases. Now, is that to say that we can't do more and that we can't do better? I would argue that we can all, to use an often repeated phrase, we can always do better. And provinces and territories, as you know, have largely the jurisdiction to improve healthcare services, but the federal government has been there all along to help improve access to palliative care and will continue to do that. I'll just say that when the physicians talked to us, they really felt that this was not an either-or conversation. This really was about adding on, as I think MP Thériault has pointed out, a certain degree of autonomy for people to decide at what point it was for themselves that they wanted to die with circumstances that they could control themselves, regardless of the situation of palliative care. Palliative care, as we know, is a critically important component for people that are experiencing long-standing severe illness or death. But in some cases, people, even with the reception of palliative care, still want to end that suffering. And that is the premise of this bill, that it's based on dignity and choice. Certainly something that we heard echoed through the practitioners that were so generous with their time to share their experiences with us.
Thanks very much, Madam Minister. I want to do something now that the Westminster Parliaments don't often allow for, and that's for opposition members to acknowledge the work of a government minister. So I just want to say that I first ran across requests for medical assistance in dying at the height of the AIDS crisis, when HIV diagnosis was a death sentence because we didn't have treatment at the time. And so the minister knows I've been dogging her for a long time on getting better access to testing and treatment for HIV. So I just want to acknowledge the approval yesterday of the first HIV self-test kits, which will help us down the road to eradicating HIV. And so I know that doesn't happen often, but I just wanted to take a moment to do that. When it comes to Bill C-7, I do want to say the same thing that many others have said. There is real suffering going on in the system for those who face terminal illness. It's suffering by the patient and also by their families. And so I'm very happy to see C-7 come forward at this time to try and address especially the case of those who've already been assessed and approved for medical assistance in dying and fear losing capacity. We've had famous cases, and we've had, in my own writing, personal cases where I've had friends who've had to go early for fear of loss of capacity. So I think this bill is important. But my question this morning, I guess it's to Minister Lametti, is about the other issues and the statutory review. It's very important that we deal with the very complex question of advance directives. I believe it's also very important that we thoroughly examine the question of mental illness and those who are suffering from mental illness. And the question of mature minors, which were all mandated in the statutory review. And as well, as the minister knows, I would like to see us add to that statutory review the question of whether there are adequate safeguards when it comes to other vulnerable populations and people with disabilities. So my question is very, very simple. I've been after the minister for months on this. I would like to see us having started the larger statutory review at the same time that we're examining C-7, so that we have a place for those concerns to be fully aired and fully studied in public. So, Mr. Minister, when will we see a mandate for this statutory review, and when will we see a proposal to get it underway?
Thank you, Mr. Gerritsen, for your question and your comments. You know that I agree with you in principle that we need to get that we're committed to that other review. I can't commit to the form yet. My priority is C-7, but I'm going to work with you and with other members around this table, all parties, to make sure that we fulfill our obligation. I'm sorry that I can't say more than that right now.
And Madam Chair, can I just jump in for 1 second? I just want to clarify that the $6 billion that we gave in budget 2017 included palliative care, but was also for things like mental health and home care.
Mr. Garrison, you have 30 seconds if you'd like to add anything.
Well, just I want to say to the minister that I do fundamentally disagree with him when he says his priority is C-7. C-7, yes, for those who are suffering is important, but the other issues on medical assistance are equally important. And I firmly believe that Parliament could walk on two legs here, and that we have the capacity to deal with C-7 at the same time as a statutory review.
Thanks very much.
I don't dispute at all the importance of I know they're equally important, and I agree with you on that. We'll have to disagree procedurally for hopefully a very short period of time.
Thank you. Thanks very much, Minister. Keeping a close eye on the time, we're now moving into our second round of questions. So we have 5 minutes for the Conservatives, 5 for Liberal, 2.5 for Bloc and NDP. And I'm hoping to get to the last 10 minutes between Bloc and between CPC and Liberals as well. So please try to be as concise as possible. I'd really appreciate it. Mr. Cooper, you have 5 minutes. Please go ahead.
Great. Thank you very much, Madam Chair, and thank you, honorable ministers, for being here and for your presentations. Minister Lametti, you stated that the legislation excludes sole mental illness, and it is true that the legislation does provide that mental illness is not considered an illness, disease, or disability. However, I would note that pursuant to the criteria, a physical or psychological suffering is the test. And so could you address the concern about an ambiguity in that when you remove reasonably foreseeable and leave psychological suffering, arguably the legislation does in fact provide that or could open the door to mental illness?
Thank you, Mr. Cooper, for your question. It's a very good question and a very important question. The reconciliation of those 2 points is the following. Certainly, psychological suffering is a factor that can be part of a larger set of factors that would potentially qualify a person for medical assistance in dying. What we have done is say that mental illness can't be the sole criterion at this stage. We need to study that further. As I mentioned in my opening remarks, there isn't a consensus, and it's a very deeply felt fear in the experts that we had spoken to and in the medical community, in the CCA report as well, that we still need to know more. And so it is as a sole criterion. It can be a factor with other criteria present, and so that's the specific reconciliation of the point that you bring up.
But it would not have to necessarily involve a physical illness. You would concede that.
If it is the sole criterion, then that person at this stage will not be eligible for MAID. That will wait. And sadly, because these are, these are tragic situations, and people are suffering. There's certainly no view on our part that psychological suffering is any less serious than physical suffering, but it can't be the only criterion as we have framed it.
I guess the other concern, just to follow up on that, is that the legislation provides for mental illness being excluded, but there's no definition of mental illness. And there is no definition of mental illness anywhere, in fact, in the criminal code. So it leaves practitioners in a arguably difficult position to understand and interpret the legislation correctly. When you strike down the reasonably foreseeable criterion, which did make it very clear that psychological suffering or some form of mental illness could never or should never constitute a basis in which the procedure could be carried out.
Well, look, we were listening to the medical community. We were listening to experts. We were listening to families and others, and they were suggesting this particular wording. We can look at the wording if there's a way to make it clearer. But as I certainly made clear in my response to Mr. Garrison, this is an important issue that needs to be studied. It needs to be studied quickly and needs to be addressed quickly, because people are suffering out there, and we want to help reduce their suffering and give them the fullest set of options that every other Canadian has.
And I will lastly ask you, Minister, if you can address expanding the criteria to provide for an advanced consent in albeit limited circumstances, despite the fact that the expert panel working group provided that there were significant knowledge gaps and a lack of consensus. So why is the government proceeding with that in the face of those concerns, all the while preemptively moving ahead of the legislative review?
Well, those CCA studies in this particular regard don't represent Canada in 2019. We had Audrey Parker's case. We had other cases where it became clear that a very limited kind of consent, as we are proposing in this legislation, was in fact widely reflective of a consensus across Canada. The outpouring of support for Audrey Parker, or an Audrey Parker type amendment, was clear across the country. So I would disagree with you, Mr. Cooper, to say that there was no consensus on this particular point. And I would say that the Canadian Council of the Academies report on this particular point would actually be outdated. There is a clear consensus on this, and that's why we're doing it.
Thank you very much, Minister Lametti, and thank you, Mr. Cooper. We're moving Mr. Sangha for 5 minutes, please. Go ahead, Mr. Sangha. The floor is yours.
Thank you, Madam Chair. Thank you very much, and thank you, Minister Quattrolo. I have got two questions for you, Minister. Number one is, Minister, in your remarks in the House on October 21st, you discussed the government's effort to engage in extensive consultation with the disability community to hear their concern about medical assistance in dying. So, Minister, can you share how the concerns of disability community are reflected in the legislation?
Thank you for your really important question. There has been extensive consultation, as my colleagues have said, and we all have spoken directly with disability advocates, disability rights groups, and individuals. And as I said in my remarks, we heard both about the long fought battle for personal autonomy and choice, but also for the concern that nothing we do in any way devalues an individual's life by saying that some lives are more valuable than others. And that's a really important distinction to be made, because in my mind, in our mind, they're not opposing views, that it's not a divisive as sometimes it's been portrayed. Listen, we've been very clear that this law is based on equality rights, both the personal autonomy rights and the equal value of each right. But what we heard was we had to make sure that people had a choice in front of them, that they knew what the options were available to them, that they weren't going to choose to end their life because they didn't have the proper disability supports around them to make their lives meaningful and valuable and productive and healthy. And so that's why we went so far in the second, the non-end of life track, to make sure that people knew, and there was an obligation on medical practitioners to discuss counseling, mental health supports, disability supports, community services, and palliative care, and make the assessment a minimum of 90 days. We know, as I said, that in some places in our country, it's easier to access MAID than it is to get a wheelchair. That shouldn't be the case. That isn't what this law is about, but we wanted to make sure that we spoke about the Charter and the UN Convention. And I am committed to working with my provincial colleagues to make sure that people are making a choice for reasons related to their circumstances, but not their social circumstances, not their lack of housing, not their lack of equipment, not their lack of employment. It's really hard to talk about this in the context of amending the criminal code, but it still needs to be talked about. And that's why we put such effort in the second track to, provide access to alternatives for people who may not think they have any.
Thank you, Minister. My second question is, Minister, we have heard from parents who have children with disabilities about their fears that their children, when they grow older, will pursue MAD because of their disabilities. Question is, Minister, can you please help alleviate the anxiety of these parents and share how the legislation would prevent this from ever happening? And perhaps more importantly, can you please discuss the steps our government has made to create a more inclusive nation and treat persons with a disability with equity and equality?
Thank you for the question. Really, again, important conversations, and we're not shying away from these conversations. It worries me deeply that any child would be sent a message that their life isn't valuable or equal to another, and we are, for lack of parliamentary words, hell-bent on making sure that's not the case. We've moved a long way in this country on disability rights in the past 5 years, starting with the Accessible Canada Act and the consultations in that act committing to, in this legislation, a human rights-based approach to disability inclusion, which lets us get at the underlying systems. You know, a lot of it's provincial, and I'm not saying that as an excuse that we don't have an important role at the federal government, but what it means is working collaboratively with provinces to make sure people have meaningful options. We have a commitment to work with the provinces and territories on this. We have committed, as I said, to a very action-oriented disability inclusion plan, which includes the Canada Disability Benefits, which will give people income, maybe opening up their choices, which includes an employment strategy, again, providing options and choices, and includes an overhaul of our federal government eligibility for disability programs and services, again, giving people options. I never want to be even, you know, I don't want anybody to think in Canada that their lives are less valuable than anyone else's. And we are very, very committed to making sure that message is not sent.
Thank you very much, Mr. Qualtrough. Sorry, Mr. Sangha, your time is up. Moving on to Monsieur Thériault. You have 2.5 minutes, Mr. Thériault. Please go ahead. The floor is yours.
Alors, je fais court.
I'll be quick. Mr. Garrison brought up an important point. This bill is interesting, but it does leave a few delicate, sensitive elements uncared for. And I'm wondering if there should be a review on 2020. I think once it has been adopted, would you be able to, following the adoption of the bill, would you be able to commit to be able to work on the weaknesses of this legislation to be able to continue with our work of review? Because this reflection is requested. So I think it might be an interesting compromise to be able to reconcile the different positions. So would you commit that following the adoption of C7, we would be able to continue to work on the 7 sensitive points of this bill? You know, Mr. Thériault, my history with all of this. So I, of course, would like to be able to look at such questions, sensitive questions, and so that's what I've also told Mr. Garrison. So I can commit to doing my best to be able to work with the leader, Mr. Rodriguez, and with the other parties, and to work with you also to be able to, through the House of Commons, be able to have a committee set up as soon as possible. So I can commit to doing my the best I possibly can to collaborate with you and to have a committee set up as quickly as possible. I can't, of course, guarantee anything concrete because, of course, there are other issues with leaders in this parliament. But you do agree we shouldn't be waiting either 4 years or a year. Yes, I agree totally. And as you know, it's a priority for me, and this, you know my history. Yes, because there's a difference between mental health and all of the issues of cognitive degenerative diseases, and all of that has to be looked at in the case of advanced requests. Yes, I'm hearing the same things as you across Canada, and I think it's important that we pursue the issue. So my time is up.
Yes, it is. Thank you, Monsieur Thériault, for recognizing that. And just quickly, I recognize that it's now 12 o'clock, and I would ask the consent of the committee and the witnesses to be able to go through maybe 2.5 minutes each for Mr. Garrison, Mr. Lewis, and Mr. Zuberi. If I have the consent of the committee, just give me a thumbs up so that everybody has that option to be able to ask your last round. Thank you very much. So Mr. Garrison, please go ahead for 2.5 minutes, followed by Mr. Lewis and Mr. Zuberi. Go ahead, Mr. Garrison.
Thank you very much, Madam Chair. One of the reasons I'm very confident that there's public support for Bill C7 is the fact that it maintains a very high bar for accessing medical assistance to dying, in that someone must be suffering from an incurable condition, they must be in an irreversible decline, and they must face intolerable suffering. However, there are some who I think oppose the concept of medical assistance in dying, who have been using some catchy phrases, which I don't think are designed for promoting real debate about the issues. But I would like to give one of the ministers a chance to respond to those who are talking about C7 creating death on demand or creating same-day dying. I do not believe the bill does this, but I think we need to address the attempt to distort the bill.
Well, thank you, Senator Garrison. And you're right. I think phrases that you've mentioned, I can't exactly repeat them, but also referring to this bill as a euthanasia legislation, which I have heard in the House of Commons, is incredibly demeaning to the dignity of people that are attempting to access this service, and incredibly demeaning to the professionalism of the incredible physicians and other MAID assessors that I had the privilege of meeting while I did the consultation. This is incredibly personal, detailed work that a physician and practitioner does, sometimes within a team, sometimes on their own within a hospital setting or a clinical setting, with people who are in arguably what might be some of the worst conditions of their lives, who are struggling and suffering, who are wanting above and beyond compassion and empathy. And I think we all need to understand that no one takes, especially in the medical profession, life frivolously. No one considers this. No one considers this lightly as a practitioner. As a matter of fact, one of the challenges that we've had in people accessing medical assistance in dying is that we don't have enough practitioners yet who are feel that they have the skills and the ability to be able to do this work. So I think, need to respect that the professionals that are providing this support for Canadians in some of the darkest times of their life are doing so with a high degree of respect for life and a high degree of respect for individuals who are, as the practitioners themselves have pointed out, have deliberated on this decision for way longer than they've even told their practitioners. And I think it doesn't do any of us a service in Canada when we demean the individuals that desperately want this help and demean the people that are doing the work.
Thank you very much for that, Minister Hajdu, and thank you, Mr. Garrison. We're going to move on to Mr. Lewis for 2.5 minutes. Mr. Lewis, the floor is yours. Please go ahead.
Thank you, Madam Chair, and thank you all to all the ministers for appearing today on committee. Certainly appreciate that, and it's an honor to be here. Just a few statements, and I know it's 2.5 minutes goes very quickly, so I'm going to make statements, and then I'll allow Minister Lametti hopefully to answer my question. First and foremost, the 10-day reflection period. I realize that as the way that the bill is written now would go down to 0. I guess I really question as to why we wouldn't at least start with the number of 5 and give people some time to get with family, to really reflect on the decisions that's being made. With regard to witnesses, from 2 to 1, that's incredibly concerning as well, because although we'd all love to believe that all families get along very well, unfortunately, there's a lot of back and forth within families. So I have a real issue with that. You know, would it not be a fair statement that doctors being forced to refer patients to another doctor to administer MAID directly contradicts the very constitutional right that they are entitled to? And further, would it not be a fair statement to suggest that by forcing physicians to refer MAID to another physician to administer MAID is no different than someone saying, I don't believe in robbing banks, but here are the keys? So to the Minister Lametti, you spoke of suffering in your opening remarks. Would you not agree that while in the physical state of suffering of those requiring MAID is indeed met, inadvertently, physicians who have to refer patients to another against their will indeed create emotional and mental stress that they will need to live with? Thank you.
Thanks, Mr. Lewis, for your questions. They're important questions. First, let me start with the 10-day period, the 10-day reflection period. all the work, all the family consultations, all the consultations, the assessments, the medical have already been done. All the 10-day period was effectively, you've made your decision, now you've got to wait 10 days just in case you change your mind. Universally, this was in our consultations, medical practitioners and families told us all this did was force people to suffer. It was a form of torture in which people didn't take their medication in order to be able to make a decision after 10 days. The decision, the kind of reflections that you were referring to had already been done. And so it was seen to not be necessary. The two witnesses, these are just witnesses who are effectively doing a pro forma witnessing of identity. This isn't in any way medical or in any way part of the medical assessment. Again, that's already been done. All the witnesses doing is saying, Mr. X is Mr. X, and that can be anybody. We're told by practitioners and by families, sometimes it was an impediment. You don't need two people. With respect to freedom of conscience, the bill enshrines freedom of conscience. No medical practitioner is forced to give the procedure in any way, shape, or form, and we've protected that. It already was protected. We further protected it back in 2016 in the legislation. The requirement to give a referral comes from an Ontario Court of Appeal decision. So it's the courts that have told us that. And that's true in any medical setting in a variety of different areas, not just MAID, where there's a healthcare obligation to refer someone to a service in order that people who have a right to a service can get it, even though the person who is referring has a freedom of conscience objection to not doing that service himself or herself, not providing that service himself or herself. And there is a right to get the service, and healthcare services across Canada, which are provincial, have an obligation to provide that.
Thank you very much for that, Minister Lametti. And then finally, Samir, Mr. Zuberi, if you can keep your question pretty tight, that would be great. Go ahead, the floor is yours for 2.5 minutes.
I want to thank the ministers for being with us here today on this very sensitive and important matter. My question relates to safeguards, and we know that the legislation as being put forth has safeguards when death is not reasonably foreseeable. Those safeguards include that physicians have expertise, that there's one is informed about how to alleviate their suffering, and that there's serious consideration given to the person in question who's considering ending their life when, in terms of those means to alleviate their suffering. Can you touch upon why those safeguards are not included when it comes to the question of the death not being reasonably foreseeable? Thank you.
Well, I guess it's me. Thank you, Mr. Zuberi, for the question. The first set of safeguards in the end of life regime, where we have used the reasonable foreseeability of a natural death to be a channeling criterion and not an eligibility criterion. They were well known by medical practitioners and by families, and so for the most part, we've kept them. We have taken out the things that they have told us were prolonging suffering unnecessarily. Those are the vast majority of cases. Terminal cancer, people near the end, families preparing, everyone preparing for the inevitable. And so we feel we have made that part of this, for the vast majority of people, more compassionate. In the non-end of life regime, as Minister Qualtrough pointed out, we wanted to make sure that people had adequate support and information to make a decision about how they either wanted to live or how they want to die. And we were told again by experts and families and practitioners that there were in the case of catastrophic accident, for example, it's often your first reaction, well, I want to die, I'd rather not be alive. And it's only after a few weeks that and seeing what the other alternatives are, that one comes to the conclusion, you know what, I've got a lot of things to live for, and I could live this way or that way given the right information and the right support. So we wanted to make sure that those safeguards were embedded in the regime that we had. Some countries require 6 months. We have required 90 days for the assessment period. It's not a waiting period, but it's actually the assessment period when the person is consulting with their family, their doctors, their nurses, getting the appropriate options, getting consultations on supports that will be available should they choose to live, and how they might live. So we're trying to balance two very different scenarios. The non-end of life scenario is the less frequent number of cases, right? As I said, the vast majority of cases are the end of life scenario. It is what medical practitioners, maid service providers are used to working with, and we've made that, we think, better.
Thank you. Thank you very much, Minister Lametti. And I'll take this opportunity now, as we have concluded our 2 rounds of questions, to thank Minister Lametti, Minister Hajdu, and Minister Qualtrough for taking the time to answer these very important questions about Bill C-7 and medical assistance in dying. Thank you for your efforts and your hard work. We will suspend the meeting for a minute while we switch our witnesses in for the second round. So meeting suspended for about a minute. Thank you, everyone. Thanks for joining us, Minister. physician, Dr. Tanya Dawes, who is also a family physician. And then we have Dying with Dignity Canada, Senator James Cowan and Helen Long, who is the Chief Executive Officer. And then we have the Quebec Association for the Right to Die with Dignity with Dr. Georges L'Espérance. So we'll go ahead and start with Dr. Ramona Coelho. Please, the floor is yours.
Sorry, I'm trying to figure out how to, okay. My name is Dr. Ramona Coelho, and I practiced home care in Montreal and now practice in London, Ontario. My home care patients were ill or disabled and homebound, and in London, I care for many Syrian refugees and other people. I would say half of my practice is comprised of people with disabilities. I'm here today to say that I think that suicide prevention must remain a priority and standard of medical care be given to Canadians. I work with vulnerable patients, and I'm concerned that I won't be able to protect them from transient suicidal ideations if this bill goes forward without some amendments. Also, an amendment protecting conscience is equally necessary to respect diversity and autonomy on this controversial issue. Many of us, regardless of religion, who work with the ill and disabled could not facilitate a lethal injection by request solely on our medical judgment. I had a lovely 70-year-old lady losing weight and requesting death for months. Looking into her condition for cancer and other issues didn't give me clarity, and it turned out that her son, who had moved in some months before, was stealing her money and not feeding her. Following my clinical workup benefited this lady, but I know that if I had a 90-day framework to try to outrun her death wishes, I would have facilitated a death driven by elder abuse and financial abuse. As I shared, many of my other patients have disabilities, rheumatism, fibromyalgia, multiple sclerosis, organ failure, and many others. The existential crises and hardships of these people are real, but their death wishes are often transient, and we need time to apply good medicine. We will become a place in Canada where you can receive a lethal injection before the standard of good care is actually applied if this bill passes without amendment. Pain clinics, psychiatry, rheumatology, neurology, they all take more than 90 days to initiate contact, meeting, education, and treatment plans. Bill C7 is currently constructed so that a vulnerable patient can choose within 90 days to have a lethal injection and only know that services exist without actually having gone through the standard of good care to see if that resolves their suicidal ideations. There should be some amendment for that, for lethal injection for those who are not dying, so that it should only be for people who have gone through psychosocial education, who've had actual good medical care, not just been offered. To know that an injection for pain relief exists and be offered it is very different from actually having experienced that pain relief. And wait times, at least where I am in London, Ontario, are very long. I also urge a conscience amendment. In Ontario, many doctors have retired or left palliative care and other things, and none of these outcomes increase patient services anyways. With this bill, many physicians across all specialties will find themselves under duress. We have a made to mad statement with 945 doctors across all specialties across Canada who are saying that this bill needs amendment. Thank you.
Thank you very much for that, Dr. Coelho. Really appreciate your concise remarks. We'll move on now to Dr. Tanya Dawes for 3 minutes at the minimum. Thank you so much. Please go ahead.
Thank you for allowing me to speak. I'm a family physician from Vancouver Island, servicing rural communities, and have been a physician for 20 years in total, and have done MAID since 2016. And I wanted to thank Parliament for the time it's given to study Bill C7, because I know that for some, it will seem to never be safe enough. And from reading a House of Commons debate notes, I could see that for many, there were specific fears relating to disability, vulnerability, and slippery slopes, and frustration by other members that the bill never seems to go far enough. I wanted to specifically focus on 2 issues, but I did in my brief provide more information, specifically addressing the MAID process as to how we assess patients, the nuance, the detail involved. And I share the same practice profile than my colleague, and can state that in the 4 years of doing MAID, I've not ever seen vulnerable patients being abused, because that is something we are very specifically looking for in MAID assessments. And we spend much more time than we spend with regular patients, over months if needed, to come to eligibility decisions, even if there was just a 10-day wait period in the past. So as MAID providers, we bring an added level that many are palliative care physicians, many work with disabled patients to start with, and we feel that our moral grit is strong enough to ensure that we are another layer of comfort and care for those patients, more so than just being MAID assessors. I wanted to, however, also take the time to spend attention on two separate issues that I think will flow forward on a practical level in MAID from Bill C7. And the first is just around the clarification of expertise. And in this brief, I wanted to focus on the fact that family physicians and nurse practitioners provide the majority of the backbone of Canadian healthcare by doing primary care and also being co-pilots with our specialty colleagues. And that as expertise and the bill, as mentioned, we realize with appreciation is not to change the equitable access to MAID, but to rather ensure that people are more in place to assess these patients thoroughly, especially when we talk about vulnerability and disability. I do, however, feel that, most family physicians, specifically who deal with these people for decades, knowing them for decades, as their primary caregivers, are probably in the best position to help them. And most MAID providers come from this field, same as nurse practitioners. And in medicine, where we feel we are not equipped medically or knowledge-wise, or we feel we're missing something, that's when you always phone a friend and refer to a specialist or another colleague. So I don't think that in MAID assessments, that process will be different. And we have shown that in the MAID community, more MAID providers have done palliative care courses. And we are all looking at courses to help us with cultural sensitivity, as well as with vulnerability and sensitivity. And we're all willing to do training to ensure that we will have enhanced skills to make it safer. I do think the one thing that will be very difficult with how expertise is defined in C7 is that it may be very difficult in some illnesses to have a MAID assessor feel that they're an expert. And it may be impossible, for instance, to find a neurologist who's willing to be an expert and be a MAID assessor. So I would like to propose the idea to the committee that perhaps the two MAID assessors, if they feel they are at expert level, could continue in that role, but where they feel that none of them could be expert enough, that they could perhaps refer to a third expert, such as an addiction specialist or a pain specialist, who are not actual specialities per se, like surgery, for instance, but that they can ask for a consultant opinion, which is pretty much what we are doing at the moment with C14 when we refer patients for a formal capacity assessment. The assessors, which are usually psychiatrists or geriatric psychiatrists, are not comfortable being MAID assessors or providers, but they're happy to be consultants. Thirdly, I would like to just address in terms of the final waiver that the specified day as a choice for patients can provoke unintended harm by causing anxiety. It's very hard to write down a day, but patients may be more comfortable writing down a period that they would give for that advance consent. This should also be transferable to other providers, as we do have holidays, conferences, we may be in COVID quarantine, and another provider may have to be able to act on that waiver. And thirdly, we are concerned with obstruction from third parties, such as with the recent Nova Scotia case. And if we deem that the patient is not suffering and family agrees, that we can stand back.
Thank you very much, Dr. Dawes. I appreciate your time. We will go on to Dying with Dignity with Senator James Cowan and Helen Long. Please go ahead. Your time starts now.
Good afternoon, and thank you for the opportunity. Senator Cowan and I will be splitting our time. For 40 years, Dying with Dignity Canada has been committed to advancing end-of-life rights and helping Canadians avoid an unwanted suffering. Our role is to represent the 86% of Canadians that support the 2015 decision in Carter versus Canada that struck down the prohibition on physician-assisted dying. We've done a number of studies and surveys over the years around end of life, and our results are largely consistent with those of the federal government in the spring consultation. In our view, the experience of Canadians within the MAID regime has been overwhelmingly positive. However, experience and research would demonstrate that there is a need for some improvement. We're here today to speak in support of the legislative amendments that have been put forward in Bill C7, although we will briefly address concerns. The changes do address the need for personal autonomy and also importantly demonstrate compassion for individuals. We are pleased to see the removal of the reasonably foreseeable natural death eligibility requirement, which infringes life, liberty, and the security of the person guaranteed in Section 7 of the Charter. Removing this clause ensures constitutionality for the individual and also their choice to end their life at the time they choose. Jean Truchon and Nicole Gladue spoke for hundreds of Canadians who've been excluded to accessing MAID until this point because they were not imminently dying, although they were still experiencing constant physical pain and suffering that was intolerable to them, and they have carefully considered their decision. We commend the government on the inclusion of Audrey's amendment, allowing waiver of the requirement for final consent for those who are assessed and approved for MAID but may lose capacity in advance of their date. This is something that 85% of Canadians support. We believe this waiver of final consent should also be extended to those whose death is not reasonably foreseeable. Many of you will be familiar with Audrey's story. Sadly, it's one we hear every day, and we are forever grateful for her advocacy and appreciate the acknowledgement of the pain caused to individuals like her in this amendment. Senator?
Go ahead, Senator. Senator Cowan, do we have him on the line? Senator Cowan, can you hear us? I can see you, but we can't hear you.
Shall I finish this statement, Madam Chair?
You know what? Maybe we can come back to Senator Cowan, and we'll move on to the Quebec Association for the Right to Die with Dignity with Dr. Georges L'Espérance. And if I can, in the meantime, have somebody from IT give Senator Cowan a call to fix his issues. Go ahead, Dr. L'Espérance.
Yes. Hello. Hello. Ladies and gentlemen, thank you very much for this invitation. My name is Georges L'Espérance. I am chair of the Quebec Association of the Right to Die in Dignity. I am a retired neurosurgeon. I practice myself for MAID, and as such, I am a part of a group, a discussion group in Quebec of doctors who offer this ethical and compassionate last care. And we have very interesting exchanges. These remarks that we have together are helpful for our citizens and nourish her. We would like to thank all of those who have listened to patients. And this is especially for people who are alone. I think that it is important to have a written request before one witness and of the possibility for somebody to be able to give a personal care to be able to be an independent witness for that person. The 10-day reflection period has followed a clinical logic, and the waiver to the final consent is also a good idea for the reality that we're all aware of. We do agree with this written waiver for final consent, as well as 3.3 and 3.4 with respect to all gestures with respect to care administered. We do believe that this last measure at 3.4 be revised in 2 years with the experience that we'll have received and that may be eventually rescinded. There are three major points that we think that Bill C7 should be improved. We think that we should eradicate the reasonably foreseeable death and we can see that the most vulnerable don't need more protection to be able to give them a just access to a MAID. And we believe that this is a non-medical concept for doctors, because it puts people within a group and it doesn't deal with individuals. And we think that the 90-day minimal evaluation period should be taken away, as well as the 10-day period. We think this is an insult to intelligence and to the suffering of our patients. The repeal of this criterion will also give a more homogeneous access to MAID, and will make it an objective medical process. With respect to medical illness, with all respect for for those who are involved, we think that it is important to take away this clause and have a 12-month non-applicable period where the professionals from each province will be able to work together to see, and they will have a legal obligation to define a common clinical framework. With respect to all capable people who have received a diagnosis of Alzheimer-type neurodegenerative cognitive disease, they should be able to give written advance directives with one witness, and whatever that they be able to have access to MAID. And we also firmly believe that people should have a right to die with dignity, and there should be an absolute ban for people who are not capable people for a reason of mental deficiency, and that they may not have access to this procedures. Thank you.
Thank you very much for that, Dr. L'Esperiance. Much appreciated. We'll go to Senator Cowan. If you are able to communicate at this time, we'll just do a check. No, we still don't hear you. Can you just check on your mute button, the arrow upwards, and just ensure that it is your headphone or a headset that is selected for your microphone? You're on mute now, so even if we could hear you, we can't hear you. No, we unfortunately still don't hear you, Senator. What I'll do then, as we are running very short on time, is that I'll ask if you can provide some written submissions, which I know you may have done already, with respect to your comments today, and we'll start with the questioning. If I can please have IT call Senator so that he can at the very least participate through the question answer period. We'll go for 6 minutes now, 6-minute rounds. We'll start with Madame Finley. We'll go on to Mr. Virani, and then Mr. Thériault, and Mr. Garrison. So go ahead, Madame Finley. The floor is yours for 6 minutes. Thank you.
Thank you, Madam Chair. My questions are primarily for Dr. Coelho, who I found to be a very compelling witness. Doctor, in 2017, you expressed concerns about the duty that doctors who don't wish to participate in MAID have to refer patients to another physician who is willing to give the patient the end-of-life procedure. Could you speak to this referral issue and how the expansion of MAID to those whose death is not imminent would affect doctors who are not willing to participate?
Thank you very much. The preamble of C14 did speak to conscience protection, but that is not an enforceable part of the bill. And unfortunately, in Ontario, the CPSO has a policy where doctors have to arrange and facilitate for medical aid in dying and what will be now assisted death for those who are not dying. At that time, Hindu, Sikh, Muslim, Jewish, and Christian groups which are part of the submission, all reached out to the government saying that they needed further conscience protection for their adherent physicians. But regardless of that, everybody has a line. And this is something that people feel very strongly about. I understand, I hear Dr. Dawes that this is for her, something that she feels that she's being very merciful and compassionate. And I myself, who take care of very vulnerable people, have come to the opposite conclusion, where I feel that they come to me and I'm trying to offer them safety and protection. And when they are in a safe space and express their death wishes, I can try to work on creative solutions for them. I will not deny them information. I will not tell them what, obstruct them. But my job is to be in their corner and fight for them to want to live again. And that's because I've had many patients that I've done just that. And so it would be very good in C7 if we had an amendment that speaks to conscience protection, not just in the preamble.
I appreciate that, Doctor, and also your comments regarding transient suicidal ideations and the need to apply a good standard of medical care and time for specialty consultations, which, as you pointed out, and I think we all know, takes some time.
Not only that, this will make us the most permissive euthanasia regime in the world, in the sense that usually euthanasia is a last resort once we've tried to help people want to live again. But the way the bill is written, and I want to acknowledge Dr. Dawes says she spends months, so she acknowledges that it takes more time sometimes, and to have that kind of protection so other doctors who might not be as conscientious as Dr. Dawes, written in a bill that is a life-ending bill, I think is very important.
Thank you. In a recent op-ed you co-wrote for the National Post, you wrote, instead of using our resources to increase healthcare personnel, improve our quality of care, enhance our palliative care options, and ensure quicker access to psychiatric care, our federal government seems more interested in fast-tracking death on demand and dismantling the MAID safeguards that were put in place a short time ago to protect the vulnerable. Do you have any examples from your practice where MAID was considered by the patient because the resources for treatment they were receiving were insufficient?
Yes, I have had many such death wishes of patients who've had strokes, and during COVID, there was not enough help to come to the home and couldn't open the containers for them to eat. I take care of very, very marginalized patients. So constantly fighting for things like housing, resources in the home, social support, pain control, access to meds that they can't afford. There are many barriers that lead patients to have death wishes every day. And it is a conscientious doctor on both ends that who's going to spend that time with them, but we need that written in the bill.
Thank you. Advocates for persons with disabilities in my riding are extremely concerned about the specific expansions of MAID under Bill C7, especially the elimination of any reflection period and signaling by the Liberal government of a desire to expand it even further through the unnecessarily delayed statutory review. I wonder if you have a comment on how you see there could be better safeguards for vulnerable people.
Well, I think that, this consultation was supposed to be an extensive consultation, and I'm really hoping that it goes forward that way. It is very interesting that out of everybody who's here, most of them are MAID lobbyists. The Canadian Council, the Council of Canadians with Disability, the Canadian Association of Community Living, has actually said this bill is very bad. And it has like 70 signatories, different advocacy groups for people with disabilities. You guys need disability experts to speak to you about what they consider as dangerous in this bill. You guys need expert physicians like neurologists, physiatrists, stroke specialists, psychiatrists to weigh in on safeguards. We're talking about ending someone's life. And I understand that some people perceive that as a merciful act. But I think that everyone still agrees that there's no problem with trying to make sure that people who have transient suicide ideations are not killed, and that everything is offered to them so that they could go on forward. So I strongly suggest to the committee that you have witnesses who are content experts in medicine.
I understand that 70% of Canadian citizens do not have access to palliative care. I also took note of Minister...
Madam Finlay, we're out of time. Hopefully we can get to a second round to ask any further questions. Thank you so much for your patience. We'll move on to Mr. Virani for 6 minutes. Go ahead, Mr. Virani.
Thank you. And in these 6 minutes, I just say at the outset that I think when witnesses refer to other witnesses on the panel as lobbyists in a derogatory manner, I think that's not really respectful, and perhaps that should be, the chair should make some remarks in that regard. In these, I'm going to ask 3 questions to 3 different parties. So the first is starting with Dying with Dignity and Ms. Long and Senator Cowan. We've heard from others during the course of today's discussions about the fact that the Truchon decision should have been appealed to a higher court rather than acted upon immediately in terms of alleviating people's suffering. I'm wondering if Dying with Dignity has any views on that. Minister Lametti was quite clear that it was acted upon immediately in order to address the suffering that was identified in the decision. So if you could answer that, please, in 90 seconds, Senator Cowan and or Ms. Long.
He's on mute.
Senator Cowan, you're on mute, sir.
Ms. Long?
There we go. Perfect. Please go ahead, Senator Cowan.
Yes, I'm sorry for the technical difficulties. Thank you, Mr. Virani, for the question. We very much believe that the government of Canada and the government of Quebec took the appropriate action not to appeal the Truchon decision. And we believe, as Ms. Long has said, that the response contained in C7 is the appropriate response. And we, as Ms. Long has said, strongly support it. We do have one reservation with respect to the express exclusion of mental illness, and I'd be pleased to address that if I have time, but I know, Madam Chair, that you're short of time, so I'll wait for your invitation. Otherwise, we'll cover that in our written brief, which we've filed with the committee.
Merci beaucoup. Et je vais changer.
Thank you very much. Thank you very much. Mr. L'Espérance, I would like to note the question of those with disabilities, because you brought it up several times today and in the House. With respect to your comments, Mr. Truchon and Madame Gladu did have a disability, but it was important to respect their dignity and their autonomy and to take into consideration their suffering. So what comment would you have with respect to their autonomy when they had disabilities? I think I gave the answer. Those 2 people came before Justice Beaudoin. I was there for all of the testimony, and what we can see was their great reflection over many years. And those 2 people, amongst others, people who had disabilities, had all of the help. Mr. Truchon always said that he had all of the aid also for his everyday life as a person with disabilities. This was not what he had made him make the request for MAID, and that was so the response is that people with disabilities know their condition well, and they are the ones that ask for medical aid. There is no, in dying, and there is nobody else, and whether a doctor or anybody else, that would really force them to do so.
You still have 2.5 minutes. Mr. Virani, I believe you're on mute.
I apologize. In terms of addressing what I feel is, in fairness, not accurate information, the position was put by Dr. Coelho that an amendment needs to be made to this legislation to address conscience rights. And in fact, Bill C-14 was amended at committee and validated in Parliament. Section 9, page 8 of the old Bill C-14, and now the current criminal code says, and I quote, "For greater certainty, nothing in the section compels an individual to provide or assist in providing medical assistance in dying," end quote. So it is in the legislation now. It's also in the preamble. It's also in Section 2 of the Charter. It's also in paragraph 132 of the Carter decision, where the court went to great lengths to indicate that no medical practitioner would be forced to provide a service which they don't wish to. So it seems to my mind, Dr. Coelho, that your concern is actually with the direct referral regime, which has been actually upheld in litigation in your own province of Ontario, where it was deemed to be held constitutional, the approach that is currently done. And direct referrals also occur with respect to any other provisions or treatments that doctors don't feel that they want to provide themselves. So perhaps if you could respond to that in 45 seconds and give Dr. Dawes the time to do the same. Thank you.
Yeah, of course. So referral is not something that we pass on when we're not comfortable. It's a continuation of care for what we think is appropriate. And I think that explains some ethics that I can't get to in 45 seconds. But we do not actually make referrals for things that we think are bad for our patients. That is actually the standard of ethics and integrity in medicine. And the World Medical Association, the CMA, and the AMA all support that position, as does the OMA. So the CPSO is actually the deviant here in terms of the college policy, and the fact that multiple religious, like Hindu, Sikh, and Muslim organizations—
If we could allow Ms. Dawes to answer the question, please.
Sure. Sorry.
I have a very different viewpoint. In my experience as a MAID provider, especially in people with disabilities and even advanced illness such as multiple sclerosis, the entire treatment team had been obstructing patients' access to care and actually induced traumatic stress in those patients and their families with their personal views that patients should keep on trying when they have really reached the end of the line after years or decades of illness. And my patients with disabilities who qualify for MAID under C14 have multiple times told me that they abandoned healthcare because their practitioners continue to force upon them the concepts of continuing to struggle when they were done. And we found that initially providers of healthcare, including family physicians and specialists, would abandon patient care. That stopped after provincial regulations from colleges made it clear that that's not okay. But we now actually find that patients abandon their healthcare workers and vote with their feet and actually compromise their disability care and their palliative care. And as MAID providers, we then pick that up and work on that from scratch before we even start the MAID process. So there are other unintended outcomes when people who think they're doing the right thing to protect the patient actually take it too far. And there's always two sides of a coin.
Thank you. Thank you very much, Dr. Dawes, and thank you, MP Virani. And just to address what you had noted earlier, I obviously want to ensure that our committee welcomes all witnesses, no matter how much we disagree on opinions, etc. Obviously, we want to engage in a respectful and collaborative dialogue as we endeavor into making life-changing decisions for Canadians. So thank you all for fulfilling that respectful dialogue. I really appreciate that. We'll go on now to Monsieur Thériault. Voulez-vous commencer?
Would you like to go ahead? Thank you very much. I don't think we are making life and death decisions for people who want to die. They are the only ones that are going to be making those decisions. All that we're doing is to give them the possibility of making a choice. There's no choice when we say for the last 50 years that the dignity in dying can only go through palliative care. And so that's all there is to dying with dignity. So what we're doing with this bill is to ensure that medical paternalism be put aside so that patients themselves, in all freedom of their conscience, can make a decision and that they can give their informed consent. Dr. L'Espérance, you have said that your association had the position that this bill must go further when it comes to degenerative cognitive diseases. Could you please explain what exactly you mean? What are these diseases, and why would these? Can you explain just the how and the why of your opinion there? How would it be done? Quickly, in Quebec over the last year, 76% of those who wanted MAID were those that wanted were cancer patient, and it's the neurodegenerative diseases that are where people are requesting MAID. So the requests are increasing, and they're going up as people get older into their 70s, 80s, and 90s. They get more cognitive diseases, and when they're at an advanced stage, if it's Alzheimer, they may no longer have the capacity to make a decision. So they're going to, after a stage 4, they may have a lack of dignity with respect to their own life as to what they would have thought while they were still capable. This has been studied in Quebec by a committee, and the report was tabled at the end of January. There was a broad consensus, other than religious, but other than that, religious dissidents. We believe that this advanced requests should be made at a time when somebody could say, well, when I can no longer recognize my children, for example, so it would be the person themselves that would make a decision with witnesses as an advanced request. And so that is a very short answer to a very complex problem. Is that because this type of illness, you can foresee how it will evolve, so that you would imagine that you could make an advanced request? With Alzheimer, for example, you know that once the initial diagnostics had been made with level 2, there is between 8 and 10 years. Generally, people will die. But if it's not from their illness, it will be from other complications, whether it's pneumonia or lack of nutrition or other things. Once the patient gets to a stage 4, generally speaking, their life expectancy, statistically speaking, is 2, 3, 4, 5 years. This varies, but this is an average, and this is what the literature tells us and what clinical experience will say also. So if I've understood, all of the difficulty there would be to be able to make an advanced request at the right time and in a situation where the patient would, where we would still take precautions and give them sufficient time so that they would be aware that they would no longer be able to give consent later. Yes, there would be a whole mechanism to set up to be able to ensure that there would be rigor in the process. And so this is what the majority of the elder population is saying when they don't want to be able to have to live with cognitive deficiencies. Thank you. Dr. Coelho. I think this is very good that a doctor be very caring towards their patients. But in the case of somebody who is looking at suicide and the reversibility of that desire, and if they're in a suicidal state, and if this is, if the person were given the proper treatment, they may still be suicidal. And what about that situation if they were to ask for medical assistance in dying? Because you wouldn't, there would be a situation where you wouldn't be able to offer them any treatment. And suicide has been decriminalized in Canada. Why? Because this is a reversible situation. When we talk about patients that are asking for medical assistance in dying, there, it's a question of an irreversible situation where there is suffering and where their situation is not reversible.
Apologies, Monsieur Thériault, but you hit that 6-minute mark with the end of your question. Perhaps the witnesses can answer your question in other formats, perhaps. We'll go now to Mr. Garrison, but before we go there, may I have the consent of the committee to continue past the 1 o'clock mark for at least getting through Mr. Garrison's question time, if that's okay? Thumbs up. Thumbs up. Perfect. Thank you. Mr. Garrison, please go ahead for 6 minutes. You're on mute, sir.
Well, I've been trying to get off mute. Thank you very much, Madam Chair. I want to direct my questions to Dr. Dawes, but first I want to thank her along with a number of other MAID practitioners who shared precious time with me in getting me to understand the reality of dealing with patients who are facing end-of-life issues and not with other related but also serious medical conditions. Dr. Dawes, you're one of the few witnesses we'll probably have before us who's a practitioner working in rural and remote communities. And I wonder if you could talk to us a little bit about the challenges of providing medical assistance in dying in those situations, and in particular, what the impact would be of denial of referrals in rural and remote areas.
I think I, can speak from 4 years of experience that it is much more difficult in rural areas because there's limited alternatives to patients. Just in simple terms of travel for sick people, using 2 ferries just to come to Vancouver Island would be a challenge. And they may just have one physician on their small remote island, or a physician who may fly in and fly out every 2 weeks. It has caused difficulty in the past just to get witnesses, and that's why we're eternally grateful for the amendments proposed in C7. It has been difficult for patients with disabilities and with end of life from cancer even to get adequate supports, although the work that has been done for that has always been exemplary and commendable. And we always feel that as MAID providers, we added another layer of that into it and actually enhanced the reach of palliative care and disability support, and not just have done MAID work. In terms of concerns, it is harder for patients to get alternatives if they feel that they are being blocked or not receiving information or access, and that has led to significant delays and stress to families. We've also seen that people who did not know about the alternatives often actually had suicide plans in place, and the moment they learn of all the supports, that we actually have a MAID consultation, and those things are brought forward, and we play the devil's advocate to really make sure those things have been adequately addressed and provided, that the suicide plans disappear. And those people may actually end up having natural deaths and not actually end up having MAID, because they were kept comfortable and had good care and it enhanced their quality of life. But those who then did have MAID had good access because we made it work.
Thank you, Dr. Dawes. Can you make a comment on the concept of transitional suicidal thoughts that some people are introducing this debate? Do you find that's a real factor in those facing end of life?
No, we know from our experience that patients are not sick for just a week. They learn that they have cancer for months or years. People with disabilities have told me that they are often insulted by the thought that they, made sudden and urgent decisions after having lived brave and courageous lives dealing with those disabilities, and they are very well aware of their own vulnerability in most of the cases. And they do not take it lightly that other people speak for them, and they have told me, tell them I am the real disabled, but I am being trampled on by this pretend concern for my own ability to be autonomous.
Thank you. And if I have 1 minute left here, I think we probably do. Can we give this to Senator Cowan to make any final comments if he can deal with his technical challenges?
Senator Cowan, I believe you're on mute still. You're still on mute, sir.
Is that okay now?
That is absolutely better. Go ahead, sir.
Thank you very much. And I'm sorry for the technical difficulties. If I could just conclude on a couple of points, and thank you for the opportunity, Madam Chair and Mr. Garrison. Dying with Dignity Canada is concerned with the express exclusion of those with mental illness from C7 and believes this exclusion to be stigmatizing, discriminatory, and likely unconstitutional. It's worth recalling the words of Justice Beaudoin in the Truchon decision. And she said, the vulnerability of a person requesting medical assistance in dying must be assessed on a case-by-case basis, according to the characteristics of the person and not based on a reference group of so-called vulnerable persons. She went on to say that the patient's ability to understand and to consent is ultimately the deciding factor, in addition to other legal criteria. Thank you. Just one other point, if I may, Madam Chair. We strongly believe that the 5-year parliamentary review of the MAID legislation and the state of palliative care in Canada, which was scheduled to begin in June of 2020, should be commenced as quickly as possible following the disposition of C7. More specifically, we expect that the 3 areas identified for further study in C14 and addressed in the Canadian Council of the Academy's report, namely advanced requests, mental illness, and mature minors, will be considered during that review. From our perspective, the most pressing of those 3 areas is the areas of advanced request, something which 85% of Canadians support, as confirmed both by our own research and by the government's consultation. Today, over 500,000 Canadians live with dementia, and there's no place for them in our current legislation.
Thank you very much for that, Senator Cowan. Thank you, Mr. Garrison, for allowing Senator Cowan to finish his remarks. That really helps me out a lot, and I really appreciate it. So with that, again, I understanding the time limitations as well, I would like to thank our witnesses for your time today, for your testimony, and if you do feel that there are things that you were not able to clarify or further things that you would like to address based on the questions that have been asked, please do send in written submissions to the clerk so that we can further include your expertise on this subject matter. Thank you very much. So just very quickly, we're confirmed to meet on November 5th at 11 a.m. to 1 p.m. The committee will also meet next week on November 10th and November 12th from 11 to 1 to complete our hearings on C7. So I'll just confirm with the
Point
members.
of order.
Yes, Mr. Moore, please go ahead.
Isn't it presumptuous to say the committee will meet next week? Next week is not a sitting week, and we've had no discussion on that.
My understanding, Mr. Moore, was that we had discussed this during our steering committee meeting, where we agreed that we would be able to sit during break week. So I'm not sure if now that is not agreeable with you. Can you please clarify for me for that?
Not with me, no. We spoke earlier that we would have our 6 meetings, and just the last discussion we had on this as a whole committee, we didn't speak about meeting over the break week. It would be the 2 weeks following. So 2 meetings this week and 2 each on the weeks following the break week. So when we last discussed this as a whole committee, I don't recall it being meeting on the break week. I'd have to talk to my colleagues about their availability.
That's absolutely fair, Mr. Moore. So perhaps I think the most expedient way to move past this is to perhaps, if somebody wants to present a motion to see if we can meet during the break week. Do I have any members that would like to do that? Mr. Garrison, please go ahead.
Thanks, Madam Chair. I would like to move that we continue to sit at the proposed times during the non-sitting week.
Thank you very much for that, Mr. Garrison. I don't see any hands raised at this time to speak to this. So I'll ask Mr. Clerk if you would please record the vote on the 2 upcoming meetings. Thank you.
Before I do so, Madam Chair, Ms. Finley here had her hand raised.
Oh, Ms. Finley, please go ahead. I'm sorry, I don't see the blue hands.
No, I'm sorry, I wasn't sure how to raise my hand when I'm in person. So this is taking me totally by surprise. I am away for a good part of the break week and had not heard any discussion whatsoever about us meeting during the break week. I think it's a lot to presume, quite frankly, when we have duties in our constituencies and elsewhere during the break week. And I thought in whole committee we had come to a consensus decision on the number of meetings we would have and when they would happen, and there was no discussion about break week. So I'm, you know, my availability would be very limited to do that.
Thank you very much for your intervention, Madam Finley. I see Mr. Lewis, your hand is up.
Well, thank you, Madam Chair. And it looks as though the goalposts just continue to be moved all the time. And it seems like a lot of last minute on this committee. And you know what? At the end of the day, we as MPs have schedules and very, very tight schedules. And I'm spending a lot of time throughout my riding to continue to just to throw lob balls out here to just have meetings on break week when it's our only opportunity to be with our constituents safely, of course, I think is disrespectful and absurd. So yes, it's important legislation to be discussed, but I will not be voting in favor for this.
Thank you, Mr. Lewis. Mr. Moore?
Well, I think we have to schedule time to have discussion of this type of thing. Like, this is the first I'm hearing about it that I can recall that we would be. I mean, there's a reason it's called a constituency week. It's because we do our parliamentary work, our committee work 3 weeks in the month. And then the following week is a designated constituency week, meaning the committees don't meet. We do not have any real reason that we would accelerate the study on this bill. We're well within the time frame that the government wanted to deal with it. So I'm certainly not available to meet next week. I have it's a constituency week. So like most of you, I would think that we all have a busy schedule for Remembrance Week in our constituency.
Thanks for your intervention, Mr. Moore. Mr. Garrison, you're up next.
Thank you very much, Madam Chair. I do believe in the steering committee we did discuss sitting during the non-sitting week or meeting during the non-sitting week. I know that in discussions among the whips, because of the limited resources available to the House of Commons, that there was constant discussion that committee time would be made available during sitting weeks. I too have a very busy schedule, but I think we have very important work before us, not just this bill and others. And so that's why I've moved the motion. I'm sorry if the word didn't get from steering committee to all members of the committee. Easier for me to remind other New Democrats on the committee than it is maybe for others. But I believe that we should go ahead and people should, if they cannot make it, their parties should then provide substitutes. Thank you.
Thanks for that, Mr. Garrison. Are there any other hands raised at this time? Mr. Clerk, is there anybody from the floor that would like to? Mr. Maloney, did you just wave at the camera?
No,
yes,
no.
Please go ahead. Thank you.
To speak. Thanks, Chair. Look, everybody understands the importance of this bill. Everybody appreciates the significance of getting it done. It's not the government's timeline, it's a court timeline, Mr. Moore. We've been talking about the time frame in which this needs to be done since we started meeting a few weeks ago, so this is no surprise to anybody. I wasn't on the subcommittee, but it was my understanding that we would be sitting during the break week. Look, we all have very precious time during the break week, and yes, it is Remembrance Week, but we're not talking about giving up the whole week. We're talking about giving up 2 hours on 2 separate days to do something that is critically important. And as tight as the time frame is, if we don't sit during the break week, there's a chance we could run up against the deadline, and we don't want to be put in a position where we have to rush this unnecessarily, which is the concern you have all expressed. So I think we should vote on this right now, Madam Chair, and move on.
Thank you. Thank you, Mr. Maloney. Mr. Moore, is that your new hand raised, or did you want to? Yep.
Yeah, absolutely. I mean, because I don't accept any any argument, especially from Liberal members, about any timeline whatsoever when it was the Liberal government that prorogued the House. And I don't know if we need a refresher on what proroguing means, but proroguing means that all the House business shuts down. Every bill starts over at zero. So that's what it means to prorogue the House, and this government did that. So we don't need to hear any arguments about the delay or any timelines that are approaching, court-mandated timelines. When I look at our schedule, we are on track to meet that timeline. This isn't about anything other than the fact that next week is a constituency week, and I haven't heard one compelling reason why we would all adjust our schedules, assuming people have a busy schedule next week, to have these meetings when we're scheduled to meet the Tuesday and the Thursday that we return, and then to go into clause by clause. So there's just no one has made any compelling argument why we would meet during a constituency week. I think we should adjourn this meeting and meet at our next scheduled time, which is the Tuesday of the next sitting week.
Thank you, Mr. Moore. And I will clarify that we had discussed at length in our steering committee about the timelines, the deadlines, about how we were going to meet, the technological challenges we have with respect to our meetings, the scheduling of our meetings over the next couple of weeks and months to ensure that that we are on track and that we are on schedule. So at this time, I believe we have Mr. Garrison's motion on the floor with respect to whether we have whether we should be meeting over the break week. So, Mr. Clerk, if I can please call that.
Point of order, Madam Chair. Point of order.
Yes, Mr. Lewis.
Thank you, Madam Chair. I'm wondering, can we not? So obviously, I wasn't on subcommittee. Could we not go back through the minutes of the subcommittee and to find out exactly what was said? I'm sure certainly the clerks can tell this committee what was discussed and talked about with regard to voting or with regard to sitting during break week.
I understand that, Mr. Lewis, and my understanding is also that you had a representative that was there at the subcommittee who would have briefed your party as well as all of you on what was said and discussed during the steering committee. I do believe that Mr. Cooper has his hand raised. If you would like to speak to this, Mr. Cooper.
Yeah, well, thank you, Madam Chair. And I don't believe that there was any clear consensus on sitting during a constituency week. I believe that the clerk was to come back with a proposed schedule that was to be voted on by the committee as a whole, and that didn't happen. Now, nonetheless, we have Mr. Garrison's motion before us. So in that sense, we're doing that. But
Thank you, Mr. Cooper. So in that case, then, we will call the vote for Mr. Garrison's motion. Mr. Clerk, if you can please go ahead and record the vote.
I see Mr. Moore's hand raised. Was it? Okay, perfect. Mr. Cooper?
Against.
Ms. Finlay? Monsieur Thériault?
En faveur.
Mr. Garrison?
In favor.
Mr. Kellaway?
In favor.
Mr. Lewis?
I vote against.
Mr. Maloney?
I vote in favor.
Mr. Moore?
Against.
Mr. Sangha? Mr. Sangha? You're on mute,
You're
I
on
believe.
mute, sir.
In favor?
In favor? Mr. Virani?
Yeah.
In favor.
Et puis finalement, Monsieur Scarpelli.
En faveur.
OK, so yeas pour 8, 8. Et puis nays contre 3, 3.
Thank you very much, Mr. Clerk. So we will go ahead and have our two meetings on November 10th and 12th, 11 a.m. to 1 p.m. To complete the hearings on Bill C7. We do have two meetings for November 17th and November 19th for clause by clause. I propose that the deadline for submitting amendments to clause by to Bill C7 would be Friday, November 13th at 4 p.m. Is that agreeable to everybody?
Yes, agreeable.
Can I just please actually have confirmation from everybody that you have understood that what the next couple of weeks will look like, so that we don't run into a similar issue going forward when we've discussed something and then we forget that we've agreed to something. So just to confirm, November 17th and 19th, which is the Tuesday and Thursday, for clause by clause. And then on Friday, November 13th, by 4 p.m., any amendments that you would like to submit. Is that okay with everyone? I see Mr. Garrison's thumbs up. I see Mr. Maloney's thumbs up, Mr. Kellaway, Mr. Virani, Mr. Scarpalegia, Mr. Sangha. Can I please have some acknowledgement from Mr. Lewis and Mr. Moore? And Mr. Cooper and Madam Findlay? Mr. Lewis, I see your thumbs up. Thank you. Mr. Moore? Mr. Moore?
Yeah, I already had my thumb up.
Oh, sorry, I didn't see it there. My apologies. Mr. Clerk, if you can just confirm for me with the members in the room if they are in agreement of these timelines.
Both of them gave their thumbs up.
Perfect. Thank you very much for that, Mr. Clerk. I appreciate a wonderful meeting, everybody. At this time, the meeting stands adjourned until we meet again. Thank you.
Thank you.